So my journey with uni started almost 12 years, almost now I am doing mobile bearing, especially Oxford knee. One of the things that is commonly seen that the exposure of uni is quite less in academic institutions. So wherever we do our masters, we hardly came across partial knees because it is less utilized in institution where we passed our masters. And so that's why a lot of worries, anxiety, apprehensions about its execution, as well as its longevity, especially. Most of the time the uni is criticized as a temporary surgery or like a 5 or 10 years of survival as an outcome in patients. Some consider it as a surgery for young patients when you really don't want to do total knees, and sometimes it is considered by some surgeons as a safe surgery for old age patients. So let us understand the journey and start with the indications of uni. So start with the interaction. So this is the X-rays. How many of you will select the uni as a procedure in any of these knees? So these are the X-rays we routinely see in our practice. It starts from this end and it goes to that end. And anyone who is willing to do uni in any of these X-rays? Which one? Which X-ray? Third one. So let us do opposite. Anyone for first X-ray? Okay. Anyone for second? Anyone for third? Okay, many for third, good. Any for fourth? And anyone for fifth? And anyone for all? Like this is all indications of uni. It's a progressive disease, starts from MRI reported full thickness cartilage loss with root tear. When the arthroscopist will say that this is not my cup of tea, you feel TKR is too much for these patients and they are suffering, conservative treatment is failing, and repeatedly the patient is seeking a pain relief. Of course, it's not a first thing they should start as a uni, but all X-rays are actually where you can do unicondylar knee replacement surgery. These are the common indications where surgeons select these knees as a uni procedure and they are comfortable. But this 10% you should not start with, but it can be incorporated, and this 20 also goes with proper evaluation and exposure of uni. So this is actually the scenario we see when we do so many total knees. So it is classical medial compartment, full thickness cartilage loss, ACL is good, and very common to have this kind of arthrotomy. And then you should ask yourself that what are structures that I am looking in this as normal structure. So my deep MCL, of course it is a ligament we have to consider. In total knees we do not consider deep MCL as a ligament, but it's a very important ligament. Superficial MCL is normal, LCL is normal, ACL, PCL is normal, lateral meniscus is normal, and patellofemoral joint is functionally normal, not giving trouble. Then why we really need to do total knees? Do we have a better option? Of course, we do have a better option, and this is what exactly is the pathology you should address in the knee. So the old criteria we used to mug up in the textbook is the Cousin and Scott criteria, the varus, the numbers, the flexion deformities, weight, activity. Over a period of time, it has proven to be the 7 sins of Cousin and Scott, that either the patient is too young, too fat, too active, too painful, too varus, too stiff, and there is too much calcinosis or calcium deposits. You can't do uni, and these are the 6% of knees where you want to do unis. You are not good at it because it's a once in a while surgery. So what has evolved is a physiological criteria. So there is no more numbers you need to correct. So this is very important. Varus less than or more than, you don't need to remember the numbers. Pathology is well understood. Simple radiological documentation. You did not need complex preoperative evaluation. The preserved physiology is also confirmed. It's not only pathology, but preserved physiology is also confirmed, and wrong contraindications are rectified. So what is wrong with this knee if we ask ourselves again? This is a very classical. So varus nature is confirmed. If the nature of knee is not confirmed, sometimes the knees look very benign, but they have generalized patchy tricompartmental osteoarthritis, and they are not good knees for unis. So this is the nature of this knee confirmed as a varus knee. Full thickness cartilage loss in distal femur, medial tibial, and dysfunctional medial meniscus. It starts with the locking, catching, popping, instability, stiffness after inactivity, and pain after overactivity. So that's the only difference in their lifestyle. They are walking, but they are limitedly active. So let us address the pathology here, leave rest of the knees as it is, and let us try to reproduce the meniscus, which is biologically not possible. How an artificial knee can function well without a meniscus. So what are the functions of meniscus? The congruence, that is the most important thing that we realize in total knees also, with full contact and reduced point contact pressure. The mobility, of course, the meniscus is mobile in all planes, and the compliance, but here we do not have compliance because the poly cannot change its shape. So the blessing in disguise we have it's an inlay femur, it's a single radius design. So if we talk about the arthritis, when there is a poor muscles, poor skin, poor nerves and poor circulation, we are afraid to do any joint replacement. Rheumatoid arthritis is a contraindication. Traumatic arthritis is again a contraindication. Neuromuscular arthritis again a contraindication. And post-HTO can be done in selected cases if you are good at understanding of AMOA. So common indication is enteromedial osteoarthritis and the spontaneous osteonecrosis in its healed phase, not as active phase. But this enteromedial osteoarthritis has many variables. The age, bow legs, chondrocalcinosis, deformity, effusion, flexion deformity and whatnot. These are the A to T list that comes with the enteromedial osteoarthritis. The single existence, but there are so many factors you have to consider when you plan your uni. So let us understand in a simplified way what is enteromedial osteoarthritis. So this is a lateral X-ray, the medial condyle. The red one is a loss of cartilage. Once the cartilage is gone, it is a varus in extension because the MCL is lax. But the moment patient flexes the knee, the PCL will have a rollback and now the patient has a correctable varus deformity. So this is what exactly is the AMOA. Over a period of time, the progression of the disease, the ACL is gone, and then there is anterior tibial translation of a tibia, and that causes a significant wear and tear on the tibial platform as well as the posterior condylar cartilage, and it becomes a stiff deformity. That's the stage when your ACL is usually gone and you need total knee replacement surgery. So again, let us understand, this is the X-ray, bone on bone, no tibial translation, good enough, good information we have. But if we do not have bone on standing X-rays, then what else we can do is a varus stress view. So this helps us that this is again a varus stress view has demonstrated full thickness cartilage loss on a medial condyle. So varus stress view is a demonstration of bone on bone when you do not have bone on standing and you still believe this history says there must be a varus which you cannot have on standing X-rays. If the X-ray is tibial translation and bad knees, you are pretty sure it's a bad arthritis and you are more concerned for the lateral compartment. There you can go for a valgus stress view. So all the time you do not need varus stress view and valgus stress view. Either depending on the basic X-ray or clinical presentation, you will have the possibilities of various X-rays. So valgus stress view is for lateral compartment. So if you were here, the pathology would be like this. If you are here, the pathology would be like this. And if you are here, the pathology might be like this. But still, it's all enteromedial osteoarthritis with varus deformity, and rest of the compartment and the structures are absolutely normal. So this is just a progression of the same disease at wherever stage. Lateral X-rays are important. The good ACL means the posterior tibial cartilage must be intact. We will talk about this like this. So these are the possibilities where you will have a cartilage loss like this, which is anterior or central, again anterior and central. This is absent ACL, this is absent ACL. Means a stiff knee to begin with. This comes in your hand after you examine the patient. So already you know it's a stiff knee and you expect these X-rays to come, whether it's a flexible varus or a stiff varus. So patellofemoral joint, again, it's not a common concern. The osteophytes written on X-rays that there is osteophyte on the patella, that doesn't make any difference. Medial side wear and tear is very common. Lateral side mild to moderate is common. Lateral is very, very, very uncommon, except I think in rheumatoid we see this kind of patella. So 3 in 1, what is same? Functionally intake ACL means flexible varus means anteromedial osteoarthritis. These are interchangeable words you can utilize in same form. What are the contraindications? Absolute contraindications where you cannot do uni is rheumatoid arthritis. Of course, it's a chemical disease. It affects the whole joint. Post-traumatic osteoarthritis with deformed ligaments or weak ligaments and abnormal ligament function, severe stiff knee, infection, involved lateral compartment, severe patellofemoral arthritis, and incompetent ligaments may be a neuromuscular disease. What could be your first patient? So this is a common error that I have seen, that the practice starts with selecting a wrong patient. Best to select a thin elderly gentleman with a strong bone-on-bone demonstration on X-ray, and that should be your first few cases, rather than going for a severely obese, very aristocrat lady requesting for a surgery, and you offer them uni one fine day when you are doing TKR. You are inviting a big complication for yourself as well as for your patients. So this should be avoided as your first cases. And this will demotivate the whole team, because you are struggling, you are not okay, and the whole team feels that total knee is better, let us do total knee all the time. So spontaneous osteonecrosis, young ACL deficient knees can be tackled if you are okay with dealing with scopy and plasty together or as a team, and anteromedial osteoarthritis without ACL in elderly patients. So obesity is not a problem when you do hanging leg. It makes your life very easy. Only thing, you have to be present to give the position yourself. This looks a very bad knee, and I would like to highlight that these are the same knee of left and right knee of the same patient. Theoretically, we see right side knee is more involved because you have a big osteophyte, but this osteophyte is preventing anterior translation of tibia, and this ACL is good actually. And the left knee seems more innocent and easy knee. That knee is not a good knee. So the cupola, the posterior condylar osteophyte, is a stabilizer, and it can be termed as a sagittal plane stabilizer. And this exactly is the per-operative picture. The right side ACL was intact. Left side the ACL was absent, elderly male patient. So you can, if you are okay, you can go with Oxford and they can do very well. Same way, the tibial translation, the tibial lateral spine tried to prevent the angular translations, and it helps a lot for few months or years, but it erodes the some cartilage in non-weight bearing area, and this is termed as a coronal plane stabilizer. And you can see the post-operatively there is a good ligament stability achieved, and the tibial eminence is now far away from the lateral femoral condyle. Post-HTO is not a contraindication unless it is very well understood. This is under correction. It had served a wonderful purpose for 12-13 years. Now again, it's an anteromedial osteoarthritis, and you can deal with it. Don't remove the plate. If you touch the hardware, you are finished, because your soft tissue sleeve is completely unstable, and you can just remove the hardware which is necessary, and you can get away with this. This is a rare, weird, or extended indication not to start with, but it can be contemplated if it is post-HTO varus deformity. So this is an X-ray, young female patient, bilateral AMOA with bilateral absent ACL, and this is our first case where we did bilateral Oxford with bilateral ACL. Very rare, only one case we have done in last 12 years, but very happy patient at then. She's very obese, so that may be the reason she has lost her ACL. So this is last, but another indication where you can do lateral compartment uni. It has to be fixed. This was either healed sonk or maybe a progression of a lateral compartment arthritis, and this can be taken care of rather than removing the well-functioning medial side. You just add on the lateral uni, and we have very good results. So again, centralized patella. Patella should not be rotated. AP X-ray, varus and valgus, proper X-rays. We do not need MRI all the time to diagnose AMOA. Good X-rays really make sense. So medial bone on bone. Again, we are just revising. These are the guidelines available with on net also, that you can tick mark initially that you are okay to go ahead with your unis. These are the guides provided by the Zimmer Biomet, that whether you are in green zone or red zone. So again, this is osteophytes, not a lateral compartment arthritis. And most of the time we are concerned that the lateral osteophyte on the femur and tibia is a contraindication. It's not like that. So again, we are moving forward with this. Again, this is again very important. That's why I put it again. Lateral X-ray, very carefully you have to see. Examine clinically. Make sure if you do not have good lateral X-ray, bring patient to IITV, check yourself, and make sure that you are dealing with a AMOOA. And this is again a guide provided by the Zimmer Biomet to select the right patient. The functional grading is already done, up to which extent we can consider the ACL as a good ACL. So these are the grade 1, 2, 3 normal synovial damage, longitudinal splits, but friable and fragmented ACL or absent ACL is a contraindication in young active patient. And elderly patients with ACL deficient knee with flexibility can be contemplated if you feel comfortable to do your unis, because it is more safe procedure with good long-term results. So beware with OA, clinical assessment may mislead. Why you do not do drawer test or here and there? Because ACL, if it's stable with large osteophyte, you feel ACL is good. Actually, ACL may not be good because of the large osteophytes. ACL may feel unstable with bone loss. MCL may be feel short with tibia vara. MRI may mislead. So proper X-rays is most important, and clinical examination really makes sense. The validation of this guide is very sensitive. It's 93% sensitive and 96% specific. And 5-year survival of this guide as far as 99% published very well long back. So you can rely on X-rays. So take home message, menisci once were thought as useless embryonic existence and now understood well as very important biomechanical structure. And this took us almost 150 years. So where we stand for meniscal bearing uni, when even name we call mobile bearing rather than meniscal bearing, because under the influence of total knee replacement surgery. So need is 40 to 50% across the world at global level, not like developing country or developed country, but the usage is 4 to 5% that needs to be understood. And results of mobile bearing uni are quite technique dependent, and let us learn it right. So that's most important. There is a wonderful paper which shows the quality of the surgery. That makes sense. Whether it's you are a low volume surgeon or a high volume surgeon, this is not important. Your quality and the surgical technique is so important in any uni, and of course in mobile bearing uni. Thank you.
So a great presentation on the indications. So any questions from anybody? Yes.
So in song, do you feel the bone quality is good to put a uni there?
In a healed song, I think. You should not rush with the active stage, because the bones are so weak sometimes. You have to buy time, because that's not the right thing at that time.
I've had a patient where I had to shift to because the bone was very
Agree.
and the sizing is a big issue
It's not to start with. You are too experienced with unis. Then, but again, in an active state, it's better not to do Oxford as any uni.
Most of your pictures were mobile bearing. So in say a dicey ACL, whether it is actually functional, would you be inclined towards using fixed bearing as compared to mobile bearing?
Rather, I am more inclined towards mobile bearing. I personally believe it's a myth to use a fixed bearing in ACL deficient knee, because because when you have ACL deficiency, we have to understand there is more anterior translation. You are already struggling with point contact pressure on poly in fixed bearing unis, and with abnormal kinematics, the point contacts will go more posterior with more eccentric loading on the poly and tibial base plate. And the mobile bearing gives more congruence. The surgeons, those you are using worldwide, so they are more comfortable even in ACL deficient knees with mobile bearing unis rather than fixed bearing unis.
So to answer this question, Kartik, what I feel is that, if it is a ACL deficient knee, if you see the literature world over, they say that a fixed bearing is more forgiving for that. So
maybe first decade we have to. I think they are elderly people.
Probably you showed a very nice case where you did a ACL reconstruction on the bilateral lady and she's doing well. So if you do an ACL reconstruction, then probably use a mobile bearing. But I don't know whether, whatever sessions I have attended, whether to go for fixed bearing in cases of ACL deficient knee. I don't know what the right answer is. You want to make a comment, Ashit?
Yeah. So again, Kartik, on this, that, if you have a ACL deficient knee, obviously now, if you see the literature, Nick London from Yorkshire in UK, they have published a series of patients where they've said that if you have a ACL deficient knee, but functionally a stable ACL, stable knee, you can do a fixed bearing knee. and exactly they have shown 10-year results are same. So there is no eccentric polywear on those fixed bearing knees.
My concern, this is what my feeling. If I am given a chance, I am more comfortable. Maybe the second thing, if you change the design and technique for one case, out of like if 50 cases you use different design and different instrumentation, for one case maybe you are
absolutely right.
more
Yeah.
difficult to switch on with that instrumentation system when the so disturbing to you.
With your
So-
kind of experience, definitely. And what he says is right. You're used to a particular system, your staff is used to that.
Yes.
And suddenly to change
Yes.
just for that.
It
2,
is
3
more
cases.
inviting, more less optimized execution.
Because
being
the
aside, the
change
point-
from mobile bearing to fixed bearing, everything is different because the way you position the
Yes,
patient here
yes,
and there,
yes.
Exactly.
the way you take the incision, approach
Agree,
and instrumentation
agree.
totally different.
Agree.
But if you are, do you do a lot of MRIs pre-op or
Never.
all of them 100% MRI?
No,
MRI.
zero MRI.
No MRI at all. And that's something that we have to, really, make sure.
Maybe 1 in 500 patients,
So more
maybe.
and more number of MRIs you do, less and less UKR you will
Of course.
Because your MRIs
Absolutely.
will be reported by the radiologist saying that this is what has happened to the ACL, this is what has happened to the lateral compartment, this is what has happened to the medial compartment
Agree.
and patellofemoral joint.
What you're saying, Ashit, is no need to do an MRI.
No need to do MRI. It's inversely proportional. More and
Yes.
more you do MRIs, your number of UKR will go down.
I call them self-inflicted wounds.
Correct. Absolutely right. Because
They are
they don't examine the
self-inflicted.
patients. They don't check for the correctability of
I
the
always
virus.
tell patients that send your relative without a knee pain of 55-year age and read your MRI. It will be 15-line reporting. That means the next day she will have a pain or he will have a pain and she start feeling Google it and she will stop using stick in the evening.
What
So this is
happens-
mild thinning, apparent mild thinning. What does it mean?
See, they don't grade osteoarthritis. They report it as tricompartmental osteoarthritis.
Exactly.
And then if you do a uni in that patient, if that patient has a lateral pain and it happens to be medical legal issue,
Agree.
then you as a surgeon are gone. Because there is in black and white tricompartmental osteoarthritis. So better not to do MRI for most
Even
of the
our
cases.
radiologist in one hospital says, I need standing epi X-ray on varus and valgus stress views and lateral and skyline view. I will not report the report of this knee. I need epi standing. Maybe you are living 50 years back. You have to evolve, read the literature. AP standing is one X-ray, but if you have varus stress view, more dynamic X-ray, valgus stress view, well, I don't want varus, I need AP stand. So this is something they are controlling sometimes. So it is something they have to
Sahil?
evolve.
So sometimes on the valgus stress X-ray, we see that the medial space is opening up, but it's slightly more actually than the lateral side where it's sort of overcorrecting.
So it is variable. So it's as Chris Dodd always mentioned, it's a good breakfast with a technician. So technician must have done good breakfast. So he is pushing like anything because you have told that you have to give a stress and take the X-ray. So I agree. Sometimes there is lot of so lateral compartment osteoarthritis follows most of the time all or none low. So absolutely normal lateral and medial opening doesn't matter. But that definitely reflects that that patient may be obese, may be a female, and you have to be very careful not to overstuff the medial compartment or you will end up in a valgus alignment post-operatively.
And if the patient has a varus thrust gate, is that okay?
Pardon?
Varus thrust gate, AMOA?
Yes, it's
varus
absolutely
thrust.
fine. Absolutely. So many times you see that.
Yeah, so one of the prerequisites for taking a valgus stress X-ray is the technician should be empty.
Yes, not fully stomach.
Yes, please ask.
Sir, you showed one case of bilateral Oxford with the ACL reconstruction. I feel that it is a bit overdue because how would you mobilize this case?
One by one. It's not single stage.
One by one, okay.
There is a 3 months gap, 3 or 4 months gap. I don't remember. But it's, see, I don't do scopy. I am absolutely illiterate about scopy. So the scopy surgeon did this. Then we did a uni. Then patient
Now
came
we have
after
come
five-
across some anecdotal papers showing no ACL to be
Yes. As per the recent
done
Oxford usage, that
guidelines.
you don't need to reconstruct ACL because they are strong young patients with strong bones, and they stopped using ACL reconstruction. Agree, that is already their thought. So they stopped using ACL reconstruction.
And one more, what is your upper limit for the age and BMI for these patients? Means like you are more experienced and we
So age, our oldest patient is 94. So physiological age matters, I think, rather than chronological age. That physician will help you. Sometime you say your 60% patient is not fit. So it is physiological age that matters. BMI, we have not stopped any patient so far as per the BMI. Few patients, after feeling motivated with pain relief, they have undergone automatic bariatric surgery that they were reluctant to do. So we are saved in certain patients, but it's not a problem. I think it's a design that has only compressive forces, no shear forces. So BMI is not a
In
problem.
the initial cases, Mukesh, what we
Yes.
should do is probably start with the easier cases, what you showed, elderly
Yes,
gentlemen with
it's
strong
difficult
bones,
for
pains,
sure.
and,
Difficult
So
case.
one last question and we go
Thank
to the
you.
second talk.
Sorry if I missed a comment on the flexion deformity. So it is a correctable flexion deformity under anesthesia. It's a
Not
clean
necessary.
angle.
It cannot be corrected sometime because if you have a very big anvil osteophyte, the patient has a bony block. Patient will still have a 10 degrees or 5 degrees of FFD under anesthesia.
That is correctable once you take out the
Yes,
annular
absolutely.
ligament. The ones which don't
Sometimes
have,
it may not fully correct and you have to tell your patients that it may take 3 to 6 months.
but
So-
you can still go ahead with the
Yes,
uni-
yes, absolutely. You can
Thank
go
you.
ahead.
Just a last question regarding the indication. Do we ethically should tell the patient that he should take the decision between UKR or TKR, or should we advise?
You can narrate the advantages and disadvantages. You have to say you are in this particular stage of arthritis and this option has this advantages over these options. I think.
Are we ignoring MRI just because we want to do UKR? Or
Not at all. So you can get MRI done and then you take a call. Most of the time what Dr. Ashit Bhai has mentioned is right. Then you will take a call that I will do total knee.
no, I mean getting an MRI and then discussing the options. Do you think that is also a good?
So medico-legally you will not be in clutch if you have not done MRI because Oxford has published enough papers on this that MRI is not prerequisite to undergo the decision of AMOA. These are the literature that help you if anything is needed because MRI is never recommended as a prerequisite to take a call.
A hypothetical situation I am going through is that probably the patient 6 months down the line has some pain and he goes for MRI. And then we see that we have already done UKR and there was some also a compartment involved. How does that put us as a doctor into the situation of medical legal?
So that maybe you can easily say whether it's a source of pain is lateral compartment or progression of disease. That can be diagnosed. That you have to diagnose and say your patients that this is not a cause. And that may be the society, and that's why this kind of teaching programs that if someone goes to another consultant, they can say this cannot be better. You meet the primary surgeon, and he can help you out, or you can go to someone else who is more experienced with the unis, and he can help you out with this.
So you can answer this question, if you have those set of X-rays, standing weight-bearing AP, lateral,
Yes.
skyline, and a valgus stress. If you have these 4 X-rays pre-operatively, and on the basis of that, if you've decided you need to do a UKR for this patient, you are safe. There is not a problem. There is enough evidence. Now, lateral pain, lateral osteophyte, there are enough papers that even if you see a single lateral osteophyte on the lateral side of the joint, that is not a contraindication of doing a UKR because there are actually means we can't think of but what studies they do. They have done histological study of the cartilage of the lateral compartment in patients who have a lateral osteophyte, and the strength is exactly the same of the lateral cartilage pre-arthritic stage and post-arthritic stage. So there is nothing wrong with that particular cartilage on the lateral side. So as far as you have those X-rays properly tuned in, you are fine to go ahead with the UKR.
So just the last point to make. In the last session, we were discussing about using of technology. We are trying to do robotic TKRs. And here we are discussing not to do an MRI.
Of course, sir.
I'll end
See,
this discussion just by saying that you've got to decide what is your patient's aptitude, attitude, and you counsel them. See, when you consent them, you mention that there is a chance of lateral progression, there is a chance of this being converted to a TKR as and when. So I think it's all about the bond you have with the patient, on a philosophical note. So there is no end to it, Somebody asked that, is it ethical for us to advise robotic and the cost issues and all that. So I think these are variables. Conferences like this give you a direction to think. So don't be a Monday surgeon and start doing unis right, left and center. Just think about it. These conferences give you kind of food for thought, tweak your practice a little bit, start talking to the patient more, start consenting them, and then you will evolve your own algorithm when to do what. And if you feel in your wisdom MRI is necessary, do it. what the two stalwarts are saying and what the Oxford data is saying is not necessary. So I think it's an individual decision what you would like to do.
Thank you, sir.
And then you can compare any technology. Like if you're talking robots, because it's costing much, we have little attention. Put it like that way. You have a calculator on front desk, on your desk, and you are talking 2 plus 2. Let's use calculator. So does it make sense? Because it is available, let us use 2 plus 2 as a calculator. But we have a situation 2.36 multiplied by 7.86 minus 3.45. Let us use calculator. It is judicious use that determines. Not technology can never be good or bad. See, very simple. Your usage determines. WhatsApp has a lot of advantages and disadvantages. Still we use it, but how we use that makes sense. Okay.